So now we want to devote time for you. It was pretty clear when we heard from Dr. Gellin this morning that he gave a charge. When you looked at the charge from phase 1 and from phase 2, there was a consistent requirement in both charges that there needs to be and expected to be public input. So it's not by accident that this inaugural session of phase 1 starts off with public input and stakeholder input, because that will actually inform the work of this committee as we move into the future. So that's where we start, and so now it's going to be your turn. I want to just go ahead and briefly let other folks in the audience know who maybe aren't speakers, the instructions that were given to our stakeholders that will be coming up shortly. First of all, for framing their answers to these questions. One is, do you think smart vaccines could be useful to give you as you make decisions regarding new vaccine development and prioritization? So this is the idea of usefulness of this model. Secondly, do smart vaccines cover the most relevant issues related to vaccine development and prioritization, i.e. the usability of this product? Thirdly, how should we address the intensive data needs and think about the resources for data collection and standardization? i.e., what's the data library here? How do we handle that? Fourthly, this really looks at application development. In what ways can smart vaccines be enhanced? And we're quite interested in your comments today and into the future as we move forward. So that really is the application development. And then lastly, to also think about outreach. What advice can you give us regarding how best to engage various groups to use and further develop smart vaccines? So that really is the framework to kind of kick off then the public forum as we move forward. So as we start then to bring our first panel forward, let me first of all apologize because we have time frames and your comments are limited. And we apologize, but we have 25 or 30 people or groups that want to also make comments. We want to make sure they have sufficient time to make those comments. So the time for the stakeholders will be limited. What won't be limited, however, are papers that you have or further information that you want to give to this committee. So while this is a short kind of presentation today on high level, we're very open and very much would enjoy discussing and looking at further papers or further information that you'd want to give to this committee as we move forward. So with that in mind, let me go ahead and call on Paul Citron, a committee member, a retired Vice President of Technology Policy of Medtronic, and he will start our first of 3 panels. We'll have 3 panels. The first will be taking place now. We'll have lunch. 2 panels will follow. And there's also an open public sector after these 3 panels for anyone in the public to also make comments within these timeframes that will end our meeting. So Paul, let me turn it over to you for this section.
Thank you. Good morning. Because of the recent weather situation, I'm not quite sure whether all the panel members were able to make it in. So I would invite, I'll go through the list of the panel members who were scheduled to be here, and hopefully they are here. So let me call them up first and then tell you which sector of stakeholders they represent. Carole Heilman. There's quite a time lag between what I said and what I hear. Melinda Wharton. Philip Krause. And I probably should have introduced where they're from. Carole Heilman is Director, Division of Microbiology and Infectious Diseases at the National Institute of Allergy and Infectious Disease from the NIH. Melinda Wharton is Deputy Director, National Center for Immunization and Respiratory Diseases, Centers for Disease Control and Prevention. Philip Krause, from the Office of Vaccines Research and Review, Center for Biologics Evaluation and Research from the FDA. Alexander Garza, okay. Assistant Secretary for Health Affairs and Chief Medical Officer, Department of Homeland Security, Robin Robinson, Director, Biomedical Advanced Research and Development Authority, Department of Health and Human Services, Carter Diggs, Senior Technical Advisor, Malaria Vaccine Development Program, United States Agency for International Development, Richard Martinello. He's on the phone. Richard, can you identify yourself on the phone?
Yes, I'm on the phone.
Richard is Chief Consultant, Clinical Public Health, Department of Veteran Affairs. David Hammer. Is David not here? He's on the phone?
This is Colonel David Hammer from the Joint Vaccine Acquisition Program for the Department of Health.
Welcome, David. He's Product Manager, Joint Vaccine Acquisition Program, Chemical, Biological, Medical Systems, Department of Defense. Patricia Quinlisk is Medical Director, Iowa Department of Health. And Prasad Kulkarni, Medical Director, the Serum Institute of India. Prasad, are you there? Okay, we'll check with him. As you probably gathered by the various affiliations, this particular stakeholder panel represents governmental agencies. And it is my understanding that each of them did receive a copy of the Phase 1 study report, and they have been given the set of questions that Dr. King presented a few minutes ago. And what we'll do is perhaps starting to my closest right here, have each panel member just state their name so that those on the phone or those on the phone link can know who's speaking. And if I could ask you to each spend a few minutes going over those questions that were posed to each of the panels. Want to start?
Actually, Dr. Heilman, I think, was expecting you first. You want to go first? Okay.
Why don't you come to the podium? It's probably easier.
Thank you very much. It's a pleasure to be here, and I just want to begin by thanking the IOM panel members and the staff for really tackling a very large issue. Although the main attributes you identified are either known or they're surfaced when you have discussions with respect to vaccine prioritization, the recognition that we each see things and weigh things in a different way really is at the heart of the matter. And that's really underscores how difficult it is, especially now, and to begin to actually prioritize vaccines in a linear order as we had done in the past. With respect to the first attribute, which is usefulness, I just want to begin by saying that the NIH prioritizations are strongly influenced by the U.S. government's stated needs. We are but one part of the U.S. government domestic and global enterprise that is responsible for decision-making. When it comes to vaccines, okay, but within that context, I want to underscore that vaccines for HIV, TB, malaria, and universal influenza have clearly been stated as a high priority for the U.S. government and thus by NIAID. We know the impact these diseases could or do have with respect to global health, and by global health, I also include domestic as well as global economic and political security and preparedness in addition to lives saved. I seriously doubt that the impact of this tool impact that priority decision. So I want to rephrase the first question in the context of our particular mission, which is to support research that will lead to the development of diagnostics, vaccines, and therapeutics for priority public health needs, to simply ask, will this new tool be useful as we try to prioritize the use of available resources for vaccines beyond HIV, TB, malaria, and universal influenza? And the answer is possibly, but not in the way that you are currently developing it. In order to dissect that answer a bit more thoroughly, let me briefly and very succinctly explain to you what we actually do so that you understand how this tool could possibly influence our decision-making. So the NIH niche in this entire USG enterprise in vaccine development is really in three general areas. One is to support the basic research that's needed to develop the vaccines. The second is to lower the risk, both cost and failure, to industry as well as public-private partnerships involved in specific vaccines for public health use through preclinical and clinical resources available to help develop vaccines. And the third thing that we do is, when necessary, to conduct pivotal and/or supportive studies that will focus primarily on defined populations with respect to the availability of the vaccines under discussion. Given that my current responsibility includes advocates for diagnostics, therapeutics, and vaccines for almost all of the 300 pathogens we support, the current process is primarily driven by three things. One is scientific excellence, but also on occasion by advocates and by opportunities. Through scientific excellence, the larger scientific community, through our peer review system and through workshops, have quite a bit of say in what does and does not get funded. Advocates, by definition, choose to present information with their interest is most positive light, and opportunities require relationships be built. On occasion, all three of those attributes actually do come together, and that's a marvelous situation to be in. From our vantage point, the vaccine tool holds some promise if future efforts were focused to populate some of the attributes used either with standard and/or agreed to data. For example, the health considerations, economic considerations, and/or to provide some sort of summarized tables links that has been validated by the committee that would help allow us to have a structured kind of discussion and a structured way to look at things. I have a very hard time, especially in the communities that I note, about seeing how, and forgive me, but data can be tortured until it confesses. And so having an opportunity to clarify by the IOM what kind of data to be utilized will make those conversations be much more informative. It helps to level the playing field, and let me go to the next one. Usability. Let me say from the start that I would never use this software, but I would use the solid and comparable data from the attributes associated with the tool for decision-making in resource-constrained times. And again, this is because of what my job is and how I do my job. There are two reasons for this statement. First, I find that most of the information and the rich discussion, I find much more comes from that information and rich discussion than from finding a final figure. I need to have discussions. I need to be able to talk with people as to why they think the way they do and to figure out, and it's a negotiation that we often have. And secondly, although I understand that this tool is really used as a starting point to have that discussion, I don't see the need to have a common figure to start that discussion. So I find that an unnecessary intermediate vantage point. So the third area on data libraries, to me, this is the most valuable aspect of any future direction that the IOM panel should consider. Assessment of available data, ranking of the comparable data, and perhaps agreement as to what data sets, albeit imperfect, should be used for comparable discussions are needed before vast amounts of data are used in discretionary ways, and that's the do no harm approach. That system is already in place, the vast amounts of data used in whatever ways one people wants to use it, and it really is not particularly useful when you're trying to make active decisions about weighing one thing over the other. And so, again, quality and comparability of data will allow this tool to be used. With respect to application development, that's my suggestion to you is focus in on that prior to any more application development. And with respect to outreach, I think you need to consider it from the feedback you get today, whether or not you should refocus your effort, and then perhaps where you need indeed to outreach. So thank you very much. We're going to discuss later. Okay.
Next up would be Melinda Wharton.
Thanks very much, and I'm glad to have a chance to be here today to hear this very interesting discussion about the Smart Vaccine Tool. I'm very impressed by all the thought and effort that's gone into this on the part of the committee and the IOM staff, and do think that the tool that's been developed will be a useful part of the conversation as we think about vaccines. In my work, you know, we work with vaccines that have already been developed, but I think it is of value to have a level playing field to think about the different products that could be developed and which of them may be of high priority, and at least tools like this provide a structure to do that. It's not a decision. There's lots of uncertainty around it. But I think it's a useful input for the discussion. I think the big challenge, though, is and this is sort of a recurring theme as I think about these questions, is our limited knowledge in being able to characterize the vaccines we don't have yet. Those are really key factors in any assessment of how useful those vaccines would be, how important they are to us in public health, and it's difficult to make predictions about products we don't have yet. As far as the structure of the model itself, it does seem to me that it captures relevant factors in an explicit and transparent way. The model is very complex, but this is designed to capture a lot of information in an explicit and transparent way, and I think the expectation is that users would be using it for serious work that would be part of a serious discussion. I don't think the intention is to make something that would be used in a casual way. As far as data are concerned, I agree with Carole that this is a really important piece of it and could be a valuable contribution to compiling the information that's needed to actually use a model like this. My understanding from reading the Phase 1 report is that the intention is to sort of have an open source approach where things are accessible and available, and certainly once those data sets are created, I think that they could be very useful for users. But again, many important factors, and in particular the vaccine characteristics for vaccines that haven't been developed yet, are highly uncertain, and I just don't know how you address that. Experts make their best estimates, but that's where we are. As far as outreach is concerned, I think that the next step really is seeing what a model like this can do, and if it ends up being useful, I think it will be used. And again, especially if a group like IOM makes that assessment and makes it accessible. I was interested in Bruce's challenge on unintended consequences, and a couple occurred to me after you put that on your slide this morning. I think, I do see having looking at a variety of vaccine candidates from a public health perspective in a level playing field kind of way is useful, but there's a lot of uncertainties in this, and I think Carole's point about, really what's in the context of excellent science, what's the opportunity that we don't want to miss, and I think that it captures that in a very imperfect way, and it definitely, I think it would be an unfortunate event if a product that could have been very useful ended up ranking low on someone's list, and the list was seen as a list that was a decision. and decisions got made that might otherwise not have. I think that would be really unfortunate, and it is important to have it in the whole context of where we are with science. So I think I'll leave it at that.
Thank you very much. Next to offer comments is Philip Krause.
And I'm here representing the Food and Drug Administration. So I think as each of us think about the potential utility of the Smart Vaccines program, obviously we're thinking about how it could help us in our specific duties. And so if we think about the program in the context of what FDA does, it's a little bit difficult because we don't have a specific need or direct need for a vaccine prioritization method. In performing our work, we operate under the relevant statutory and regulatory framework to respond to applications from sponsors, review them objectively, and provide each sponsor with the best possible advice. Thus, our resources are allocated based on the applications we receive and the information we receive about vaccine development activity in the academic and vaccine manufacturing communities. And it's unlikely that a vaccine prioritization method would directly influence our resource allocation or activities. The premise of the Smart Vaccine Program, which, as it's been demonstrated so far, is that different users may prioritize the inputs differently and thus end up with different vaccine prioritization lists, runs a little bit against the way we look at things. From an FDA perspective, if there's a potential for a vaccine to have public health benefit, we view that fact alone as indicating sufficiently high priority to justify investment of FDA resources to make sure that the underlying regulatory issues are addressed. In order to determine appropriate regulatory pathways for novel vaccines, the information needed by FDA also goes beyond that which I think is provided at the higher level by the SMART program, and one really has to dig into the underlying data, which may be quite different for different kinds of vaccines. Just to give you an idea of how we currently gather the information that allows us to make our priorities and allocate resources, of course, our scientists regularly read the literature, they attend scientific meetings and workshops, they develop their own data in FDA's own laboratories, we have regulatory interactions with vaccine manufacturers, we have interactions with international regulators in the WHO, and we consult with our advisory committees. We also, often in conjunction with other federal agencies like NIH, CDC, the National Vaccine Program Office, as well as professional organizations like the Parental Drug Association, sponsor workshops to address scientific issues that specifically underlie vaccine development. For example, in the last couple of years, we've sponsored or participated in government-run workshops designed to address challenges and to identify and begin to address scientific or regulatory gaps associated with vaccine adventitious agent testing, with smallpox vaccine development, with cytomegalovirus vaccine development, and with herpes simplex virus vaccine development. What we found is that the interaction of industry, academia, and government scientists that it typically takes place at these types of workshops gives us the information that we need to assure that FDA is addressing the key issues that are identified by the vaccine development community as being most important. So as far as usability, I guess I can make just a couple of comments. Obviously, one concern is that many of the inputs that might be needed in order to use the program might not be available at the time that the program is used. For instance, safety and efficacy data about a vaccine, which can only be established in clinical trials. I would add that it may even be a little bit more complicated than that because efficacy in preventing long-term complications of some infections may even be more complicated to assess, and one can't know before a vaccine is tested what the likely outcome is on those kinds of measures. So I think sort of the main point I want to get across is that our data needs are at a much more granular level than can be provided by the high-level view of the Smart Vaccines program and of any vaccine prioritization list. And so to me, if I think back, and if I look over, listening to the comments made by Dr. Heilman, and actually also the question by Dr. Wittes earlier, to me, the real value of previous vaccine prioritization efforts has been in the data and the description of the considerations that were used, which then provides a good survey of a field and helps and begins then to identify where the gaps and opportunities are. And I think if producing lists helps to drive the accumulation of that kind of data, we're certainly in favor of getting that data, but we don't think that the list itself, regardless of which of the many possible formats it could take, will be of particular use to the FDA.
Thank you. Dr. Garza, I think you'd prefer to do it from your seat.
Thank you so much. A couple of apologies. So first, apology for my disability here, but be that as may, it's just a problem of getting older, and had to have some reconstruction of my ankle. So it's the benefits of not being a couch potato, I guess. But be that as it may, my second caveat is I'm going to have to leave a little bit early to get over to FEMA to do some hurricane stuff. And so if you see me get up and hobble off the stage, that's why. So I'm going to address some of the issues that I believe just the prior speaker brought up, and I think it really reflects the frame of reference that you'd be using the tool for. And I think Rod's probably going to talk about this a little bit as well in relationship to BARDA. But at DHS, we look through our problem set through a Homeland Security point of view, and not necessarily from a global public health point of view, because we're paid to do the security end. And it's not that we ignore the complete public health point of view, but our task is more on the security side. And so in that framework, I was pleased to see that there was a category, albeit at the bottom of the list, with the policy considerations. And part of that is directly what Homeland Security does, which is we feed our threat and risk modeling into the development of advanced biologics for biological terrorism, chemical terrorism, and radiological and nuclear terrorism. And that's really how we feed into the development of vaccine. Is we give out the information that says, from our best intelligence sources, this is what we think is going on out in the world, and this is what we need to be planning against. The Secretary of Homeland Security then will issue material threat determinations and give them to Health and Human Services. And then there is an apparatus set up on how we identify what the risks are and prioritize what we should be working on. And so in that way, I felt that category was very important. But again, it's, if you leave it up to us security people, we're going to weight that one very high and the other one's much lower, because that's the world that we live in. But there were a couple of other issues that I thought were also very important as well, and that was the foreign policy considerations. So for some of you who worked with the vaccine issues during H1N1, there was a lot going on behind the scenes in regards to the sharing of vaccine between different nation states. And so obviously the United States is a very wealthy country, and we have access to vaccine, whereas many of our partners who are not so wealthy but are strategically important to us do not have access to large amounts of vaccine. And you can see how that plays into the dialogue between our two countries, and how people use that for political gamesmanship, and how that can figure into your framework on what you prioritize vaccine for. And so in that point, in the global point, it might be worth exploring prioritizing vaccine that isn't necessarily a United States problem, but more of a global problem that you can use for foreign policy to foster goodwill, to not beyond the point of actually doing goodwill, but also to foster goodwill as a tool of foreign policy. And so I believe some of those things should be taken into consideration as well. I think the folks from BARDA would be much more inclined to discuss actually using the tool, since they're the ones that spend the money on developing vaccines and things like that. The part that's really difficult for us, though, is in building our threat and risk models. It's there's wide confidence intervals, because there's no such thing as perfect intelligence. It's always very tough to get. And so when you're building these models from an intelligence point of view, it's difficult to really hone in on to what is the specific threat, just because that intelligence is difficult to come by. On the data inputs, our data inputs come from our Science and Technology Division, who developed threat risk assessments for the federal government to be put into these different models that we use. The application, I think, would be most appropriately served over at BARDA. The outreach suggestions that I would have for us is just from our point of view, is the development of technology and vaccines for our biodefense and chemical defense programs. But I appreciate you inviting us to come down and talk, because we do think that this is an important segment to be built into whatever framework is going to be developed for vaccines. So, thank you.
Thank you.